HIT on a presentation for central nervous system. Please try to share your presentation so that you have control. If anything, okay, great. We see the presentation. You can go to a full screen, although.
Yeah, I just switched to full screen. Good morning, everyone. Can you see my presentation?
Very well, and we can hear you very well. Please go ahead.
Okay, perfect. Thank you very much for the introduction. I will continue in this talk with the reirradiation of central nervous system tumors. As we have just heard, the evidence available for particle therapy, especially for carbon ion radiotherapy, is still quite limited due to the limited number of centers available around the world for head and neck tumors. I must disappoint you, the evidence available for central nervous system reirradiation with particles is even less. So that's why I would like to start with a rather general rationale for reirradiation. We also discussed it in the talk before, but one really essential question as a radiation oncologist you have to ask yourself before you start the treatment is really, what is it what you're trying to achieve with the second course of radiotherapy? And this is really essential and needs to be discussed in detail with the patient, what you can actually offer, what the patient expects, and what the outcome will be. Is it really a second chance of cure? Then, of course, you might be willing to risk a little bit more if there's really a long-term or the chance for the cure, or is it just a long-term local control, meaning that you would like to concentrate on an urgent problem, on a pressing problem, but there is maybe also distant disease where you also need a strategy to deal with that, or what is a frequent reason, at least in general radiotherapy with photons, is the goal a meaningful palliation. And each of these aims might need a different dose. And as I said, it's very critical to discuss it with the patient, what you can achieve, because from a technical point of view, it is typically not a problem to perform reirradiation, but you really need to discuss what the costs for the second course of radiation are, and then what potential side effects can occur. We've just seen the summary from this really nice talk on head and neck reirradiation, how severe the side effects from reirradiation can be. And I'm not talking about grade 3 or grade 4 toxicity, but rather grade 5 toxicity, like fatal carotid blowout. So when talking about reirradiation, that typically means we had a primary cause of radiotherapy for oncologic disease, and reirradiation can actually refer to several different scenarios. Reirradiation frequently is referred to as a second course of local radiotherapy at exactly the point where you have performed radiotherapy before. Reirradiation could but also mean you perform a second course of radiotherapy due to edge recurrence, so slightly outside your high dose region, or completely distant recurrence. And again, as a radiation oncologist, you need to ask yourself the strategy, what is the reason for reirradiation? Does it make sense? So it could be you have treated your tumor, symbolized by this oval here, and then at a certain time interval in the future, you have a regrowth of residual tumor cells that might have been just outside the high dose area, or maybe also in the gradient of your previous radiotherapy, and they survived. And then the question is, would you perform radiotherapy? Does it make sense? And one important factor influencing the decision is definitely the outcome of the primary radiotherapy. If you have performed radiotherapy here and you have no local recurrence, and then you have an interval of 1 year, 2 years, 3 years maybe, and then you have a recurrence of the same disease, I would say it makes sense to think about a second course of radiotherapy. And as we all know, there could also be another situation. Whenever we talk about radiotherapy, we have a risk for secondary malignancies, typically occurring in the high dose region of the previous radiotherapy. And whenever a secondary tumor occurs within the high dose area, from a medical point, it's more critical because you need to take care of the organs at risk. What are their tolerance dose? What amount of tolerance can you assume? So you again have to ask yourself the question, does it make sense? Very important. Basically, there is no rationale to repeat an inefficient treatment. And this focuses on the time interval. If you perform radiotherapy for a tumor and then you go for first follow-up, in the first follow-up you see you had no effect whatsoever and the tumor is just continuing growing, then it probably doesn't make sense to continue treatment with the same strategy and just to give more dose. Then obviously this is not effective and you need to change your strategy. What strategies are there to improve the outcome of reirradiation? Well, you're very familiar with this slide. I've shown that in one of my talks before, and you've also seen that in the talk from head and neck reirradiation. Well, it's common knowledge that with increasing dose, we also have an increasing tumor control probability. And also from one of my colleagues, Thomas Held, who analyzed reirradiation for head and neck. We've just seen the data in the previous talk. We've seen there's a dose dependency for reirradiation, but it is true in the first course of radiotherapy, but especially for a second course of radiotherapy, because those patients are typically heavily pretreated. They have received a high amount of radiation dose in the first course. Maybe they have also received chemotherapy. Their surgery was performed up front. So those are really heavily pretreated patients. And in the second course of radiotherapy, our therapeutic window narrows even more because with increasing toxicity, we exceed the tolerance dose and then our therapeutic ratio is even smaller. So we need to think about strategies to modify that. And radiation sensitization or radiation protection might be worth. So these days we gain a lot of evidence for the use of hyperthermia combined with radiotherapy in the second course. We can also administer again chemotherapy to lower the radiation dose and to maximize the effect. Or we need to investigate the potential of combination of new drugs with radiotherapy. But also other modalities are helpful. It actually starts before the occurrence of a recurrence with improved imaging like FDG PET, functional MRI, etc. We might be able to detect the recurrence earlier when it's still at a very early stage and it might be small enough to be accessible for surgery, or if the target volume is smaller, it is typically not so critical to re-irradiate because the irradiated volume is also smaller. And of course, since this is a particle therapy course, other radiation modalities are worth to be looked into, because if you treat it with photons and you have a recurrence, there might be a rationale to repeat photons, but there's also a rationale to investigate what I call new beams like protons, carbon ions, maybe also other beams like helium or oxygen. Why would I talk about those other beam modalities? I know some of you say not again, But really, this is one of the main learning goals of this course. I would say every one of you should be able to draw this schematic of the depth dose profile of ions. Whenever he's woken up in the middle of the night, you should be able to refer this slide. I'm sure at the end of the course, if you counted that, you probably have seen it 20, 30 times, but it is very basic, but really, really essential. We know about the physical properties, so that's why I quickly go over that. We have a low dose in the entrance channel. Then here in the spread out Bragg peak area, in the tumor area, we have our prescription dose, and especially a steep dose gradient as visualized here with a carbon ion beam in water to the distal end. And with protons, we basically have no exit dose. And with carbon ions, there's still something called tail dose due to the fragmentation. But with particles, from a pure physical point of view, we have the potential to spare the normal tissue, to perform dose escalation, to achieve a better tumor coverage, especially in very, very critically located tumor regions. But it's not only about protons or carbon ions. To be honest, there are so many potential beam modalities out there that I say whenever I have to choose which beam modality might be the best, I actually sometimes feel like a small boy in the candy shop, and I'm completely spoiled for choice, because there are protons, there's carbon, argon, helium, oxygen. In the 90s, we had the experience with neutrons. We all know that this didn't work out, but still there's different options. So I try to reorganize those options. And this is quite simple. Here on the left side, we have the biological effectiveness. Here we have the accuracy, the dose conformality. And this is like a short history through radiotherapy, coming from cobalt ions, switching to X-rays like TEM MEV with 3D conformal radiotherapy, going to IRMT, passive scattering protons, fluence modulated protons, or pencil beam scanning. We reach more and more dose conformality. But whenever we talk about particle therapy, it's not only about physical advantages, but one main rationale to use carbon ions or other light ions are actually the biological properties, the increased radiobiological effectiveness of those particles. For example, here with carbon ions, where we worldwide definitely have a large experience, but also other candidates like oxygen might be interesting. Or what we, at least in Heidelberg, are very much pushing forward and are about to start again is the irradiation with helium ion. And all those light ions have in common that they have a higher biological effectiveness and that they are more efficient in killing hypoxic tumor cells. And we know about their potential to overcome classic radioresistance mechanism. This is helpful in the first course of radiotherapy for radioresistant tumor, but it is especially helpful in a second course of radiotherapy where the biology of the tumor also might have changed due to the first course of radiotherapy. So the biological rationale is really important. I've shown that slide before, but I really like that. As I said, I have it from one of my colleagues from the physics, but it really shows quite simple why we have an increased RBE for high LET radiation. So looking at photons or protons, the comparison is often you just throw a handful of sand in the air and then you have just sparsely ionizing events. Looking at the ionization tracks, so we see ionization is happening there and here, and looking at the damage in the nucleus, it's basically dispersed all over the nucleus. Coming to high LET irradiation with carbon ions or oxygen or other, we have a high so-called linear energy transfer. And this is all what radiotherapy is about. Radiation is nothing more than energy, which we would like to deposit at the DNA molecule, to destroy the DNA molecule of the tumor, to prevent it from further growth. And if you imagine that a DNA molecule probably has the site here of this ionization track, and you lie that across here, you can easily imagine that this densely packed ionization processes that are really, really focused. You really see the track of the ions here in the nucleus visualized by the damage here, that if you have a DNA molecule here, it's frequently scattered and it's really broken apart. You induce way more double strand breaks, which are harder to repair for the tumor cell compared to mainly single strand breaks, because you still have your twin strand where you can repair. And this is why we have an increase of direct radiation damage with high LAT radiation and an increased radiobiological effectiveness. In clinical routine, this factor, although it relies on a very complex model, between the factor of 3 to 4. So much for the general part. So now I would come to some clinical examples. Although this is a heavy ion course, as I said, the evidence available for reirradiation of brain tumors with particles or with light ions, heavy ions, is really, really limited. We also need to talk about reirradiation with protons. And a very good indication for reirradiation, very well investigated. There are several publications from US groups, from European groups, and it is also implemented in our institution as a standard of care, is the reirradiation for pediatric ependymoma. Ependymoma typically need a high radiation dose, so depending on risk factors, neurologic status and age, they receive already up to 60 gray during the first course. And during the second course, we at least aim to apply another 50 to 54 gray RBE in conventional fractionation of 1.8 to 2 gray per fraction. And those, especially if you keep in mind that those intracranial ependymoma not only occur supratentorially, but are frequently located in the posterior fossa, just next to the brainstem, maybe even with extension over the foramen magnum into the spinal canal to the spinal cord. And then it really becomes tricky, and I hope it's easy to understand the rationale for particles, because we need the physical advantages. The tumor is just next to a critical organ at risk whose tolerance dose basically has been completely used already during the first course. So we still want to treat the tumor as best as possible while sparing the healthy tissue and the brainstem or the spinal cord. And this is where particle therapy can play all their advantages. The colleagues had a look at 20 patients. First local failure, first failure was typically local. More than half of the patients, of the kids, had a local failure, so in the posterior fossa, for example, distant or even both, with a median time interval of roughly 2 years after the first course. So 2 years is really a reasonable interval. There are some serious, for example, for pediatric diffuse pontine glioma, high-grade glioma, where it is recommended, depending on the neurological status, also to perform reirradiation already as soon as 6 months after the first course of radiotherapy. But here, with 2 years of time interval between first course and second course, or time to recurrence, that's quite reasonable. Of course, they tried to undergo surgery in most patients, because still the outcome of extent of the surgery is still predictive and extremely important, as I will show you on the next slide. Chemotherapy strategies are also followed, but for ependymoma, it's either surgery and radiotherapy or nothing. So far, chemotherapy hasn't been really convincing. And the colleagues performed in involved field proton radiotherapy, so local reirradiation with a second course of 50 gray. And this is where I come to those dose volume histograms, which look a little bit scary at the first glance, because if we look at the brainstem, we see that many patients have a cumulative summed dose exceeding 90, 100, or 110 gray of the brainstem, meaning the brainstem received 60 gray max dose to a very small volume during the first course, and another 30, 40, or even 50, so full prescription dose to a very small proportion of the brainstem again. And also for the spinal cord, if you look at those values, I can easily imagine that some of you might also feel uncomfortable when prescribing a cumulative dose to the spinal cord of 60, 70, or even more gray. So these are really very critical situations. You need to be specialized on re-irradiation and really knowing what you're doing when prescribing these high re-irradiation doses. But this is also typically why those kind of treatments are performed in large centers. As I said, the extent of surgery is extremely important and prognostic relevant, because if you have no surgery, then you lose definitely your local control or overall survival, and the overall survival probability increases with subtotal resection to gross total resection. And in this cohort with a median follow-up more than 3 years, they could achieve a 3-year overall survival of roughly 80%, which is quite acceptable, but the progression-free survival was rather moderate. Unfortunately, it's often not only a local issue, but also distant recurrences play a role. And this is why these days the role for craniospinal irradiation in the recurrence is frequently discussed. Coming to adults, we're still with protons. Re-irradiation for brain tumors. We are talking here about brain tumors with WHO grade 3 or 4. This was a work performed by my former colleague Sebastian Adeberg, who is now head of department in Marburg and heading also the MID facility there. And he looked at the collective, a matched pair collective for recurrent grade 3, grade 4 glioma, re-irradiated with either 60 gray of IMRT or 50 gray of IMRT, followed by a proton boost of another 10 gray in conventional 2 gray fractionation, and looked at the outcome. And to summarize it, they had the same efficacy, the oncological efficacy, but less toxicity. And this is also important when talking about re-irradiation or setting an indication for treatment. It is not always only the improvement of oncologic outcome. Of course, this is very frequently the primary goal, but whenever your prognosis is rather favorable, as I will talk later this day on pediatrics, when you have a really good prognosis, then the improvement of the outcome might not be possible by using protons. But there's also the other side of reducing the side effects. And then this is what he could show in this matched pair analysis, because many are very hesitating to perform particle therapy, since it's still a limited resource in cases with a very unfavorable prognosis. I know many centers who say they demand at least an overall survival probability of 5, median overall survival probability of 5, or better 10 years to be eligible for particle therapy. But you can also do good by avoiding high-grade toxicity in those patients. And I will just quickly focus here on the grade 2 and grade 3 toxicity, comparing those two modalities, and we see there is a certain amount of grade 2 toxicity, but grade 2 is moderate, and no grade 3 toxicity was observed in this cohort. So with the use of particles, you can reduce the burden of treatment toxicity. Since this was a retrospective analysis, I would also shed some light on the work from Mohan et al., who published the results of a prospective phase 2 trial, comparing the hematologic outcome of either protons or photons for grade 4 glioma, glioblastoma, and all patients received 60 gray radiochemotherapy with concurrent temozolomide, so standard treatment according to Stuck, if you want so. And what they observed was less grade 3 lymphopenia. So some of you might say, wow, okay, so we have a little bit less hematologic toxicity. Is that really game-changing? We see the delta of the absolute lymphocyte count between photons and protons, which was significant. We see here in black the absolute count of protons, and in red with photons, and we see that we have a lower decrease of the absolute difference compared to photons. And this is correlating also with the tumor volume, meaning that here with increasing PTV volume, we also have an increase of the delta ALC compared to the baseline. And coming back to my question, is that really important? Yes, it is important, because there are also is evidence that the amount of lymphopenia is correlating with the oncologic outcome. For other situations, patients have a higher immunocompetency, they have less high-grade side effects, and probably by that also a improved overall survival. Although this is not really a reirradiation, I would like to emphasize that, because I said sometimes you need to go away from the aim to improve the oncologic outcome, but to reduce the side effects. And with the aim of that, you can interestingly achieve your first goal again. And because this is a very intriguing trial published by Young et al. in JCO, again, randomized phase 2 trial of protons craniospinal irradiation versus photons craniospinal for recurrent metastatic patients, so leptomeningeal metastases. So this is a pure palliative situation. And what they found out is that with the use of proton craniospinal irradiation, they actually do not only improve the probability for CNS progression-free survival, but they also improved the overall survival significantly. Here, seeing the curve in blue with proton CSI against photon irradiation. And this is rather surprising. And coming back to that, this is probably due to the sparing of hematologic recovery. So those patients might be eligible to receive more chemotherapy. They have a higher immune competency. So this sparing of the healthy tissue has an impact on the overall survival, because the oncologic efficacy is rather equivalent. And we're not talking about only a few days, which is sometimes in palliative care the case, but we're really talking about a significant amount of time. Yeah? 7.5 months against 2 months, or improved overall survival 10 against 4 months. So half a year longer survival. But finally, before I come to my conclusion, since this is a heavy ion course, I need at least to show you some data on reirradiation for brain tumors with carbon ions. But as I said, if you go and then look into the literature, you won't find much, neither for the primary situation nor for recurrent situation. And this is mainly due to the fact that so far the right strategies haven't been defined to make carbon ion or heavy ion radiotherapy a game changer for brain tumors with a very unfavorable diagnosis. So mainly talking about glioblastoma or high-grade glioma. But I will continue on that topic also in my talk tomorrow on the Heidelberg approach for clinical trials, when I give you an overview of our previous trials and ongoing clinical trials, where we also have high-grade glioma and the use of particle therapy. So looking at reirradiation, this is the work from Max Knoll on one hand here from our department, and Steffi Koms, former colleague and now head of department in Munich. And they looked in this huge German cancer consortium into a comparison of either photon reirradiation or carbon ion reirradiation for recurrent high-grade glioma. So we're talking about significant number of patients, 565, 63 with grade 3 and 479 with recurrent glioblastoma. And for carbon ion, 71 against 126. And those patients were treated between 2009 and 2018. The photon cohort received 36 gray in 12 fractions, which is a common reirradiation schedule for reirradiation of brain tumors. And the carbon ion patients received 42 to 45, a median dose of 42 gray RBE in 14 fractions. And what we can see is that we twice have an overall survival, once for the complete cohort and once the matched cohort for that new calibrated reirradiation risk score, which was published before and validated by Max Niazi. And we're talking about a median overall survival of 10.5 months for carbon ion reirradiation compared to 8 months median overall survival after photon reirradiation. So you realize I'm not too euphoric about these results, although we have a significant difference. We're still talking about a very moderate time. To be honest, this is basically almost the time the patient invests into the treatment, given the fact that it's still a very limited resource. This is definitely a topic you need to discuss with those patients. You have a option with photons for reirradiation, which is not as effective as the option with carbon ions, but you have also many other issues like logistics, travel, being for a certain period away from your social surroundings and support. So if you have the possibility, if it's no problem, if the patient can travel or is located in your region anyway, then this might be a possibility. But otherwise, I would be hesitating to refer patients with a very unfavorable prognosis just to receive that amount, that kind of treatment. Coming to an end, I would conclude as I started with some general remarks. We heard it also in the talk before. The limiting dose tolerance of the organs at risk is really not only crucial, but at least at some degree not completely clarified yet. I don't want to say unknown, but whenever you go for a second course of radiotherapy, you have to ask, what are the most critical organs at risk? What is their tolerance dose? And of course, you need to know how much dose they have absorbed before. And what is the potential for their recovery? And then those questions are not all answered. For photons, we have quite an idea. We gained, I would say, an extensive amount of experience using carbon ions. Reirradiation, not only for brain tumors, but especially for head and neck tumors, is a very common indication in our institution. and we have a high amount of experience in that, especially for head and neck. So we have a good idea of the potential for recovery and the tolerance dose. But as stated by my colleague in the previous talk, there is a need to form a consensus and to find more evidence on the carbon ion tolerance in the re-irradiation situation. Here a publication from 2018 giving some guidance on accepted and common re-irradiation schedules. And here, looking at the brain, we see that 30 to 40 gray fractionated RT, this is exactly in the window of the presented re-irradiation for glioma with 36 gray. This is not taking the pediatric re-irradiation into account, where we also go, especially for epidemioma, to higher doses, but we have cumulative biological effective doses which reach 3-digit numbers. Also, the accepted time interval is here roughly stated as at least 1 year, and you can go through that due to the time. I won't go into detail to all, but this gives you some guidance. But what I really want to emphasize, and this is on purpose, so don't think why is he uploading a blurred image? This is on purpose. Whenever you think of performing re-irradiation, do not accept any blurred, bad printout or a black and white copy that is sent you by fax and you can't read anything. Please insist always to get the DICOM data from the previous irradiation. Only with that, and then with merging the data set, with calculating cumulative DVH, you can get the best out of your re-irradiation, and only by pooling these volumetric and dosimetric information, we can really get more information on the tolerance dose of the organs at risk, when we know exactly how much dose it absorbed in the first course and how much it absorbed in the second course. So to summarize some general remarks, particle therapy definitely offers a chance for retreatment of previously irradiated tumor site. This is especially true for patients that have heavily been pre-treated. We have seen once more the favorable dose distributions, although I haven't shown now dose comparison plans because I'm sure you have seen that many times. But these steep dose gradients allow us for highly individualized treatment concept, second course of radiotherapies. We shortly discussed the rationale of using other beams with a higher biological effectiveness, especially in radio-resistant tumors. And first, although very limited clinical data shows promising results with reasonable outcome and relatively low toxicity. But of course, we are just standing at the beginning, and we definitely need more clinical studies and longer follow-ups to identify those patients who clearly benefit from the re-irradiation, and to identify those patients who do not benefit and who will only suffer side effects, to get the best treatment option available for the patient. And with that, I would like to thank you and end my talk. Thanks.
Thank you very much, Dr. Harrabi, and thanks for bringing up again the Bragg peak, the meeting point of physicists and doctors. So we have now the document where we collect the questions, and as I put the message in the chat, please take opportunity if you have any questions that they were not answered from the previous presentations, the recorded presentations. So Daphne, please go ahead and read the questions.
Yes, so the first question is at page 12, image on the left, in photons were used and in B protons, right? So I think the question is if the images in the left are actually when it's used, when we use photons and when we use protons, if you can explain.
I think you refer to the reirradiation, yeah, the matched pair analysis. Yeah, that is right. I will probably go to more details in the talk tomorrow with the clinical trial. So we had a clinical trial investigating the benefit of an additional either carbon ion boost or proton boost for high-grade glioma following a primary photon blast with 50 gray. And so some of those patients are trial patients. Some of those patients were treated in analogy to that trial compared to a historic cohort. But this wasn't a purely randomized clinical trial.
Okay, thank you. So the second question is, are there cases when you would recommend photon therapy as the first choice of radiation therapy? And should particle therapy be reserved for re-irradiation?
Very good question, thanks. Just to make sure, is that question specific for brain tumors?
I think no.
Okay.
Not at the moment.
Okay, yeah, because there it really makes a difference. I mean, I have showed that in the general CNS talk, I think, and you probably seen that also from many others. If you look at in silico comparative treatment planning, photon modalities and ion modalities, we always see that we have a dosimetric advantage of particles. But the dosimetric advantage is one thing. What is the clinical impact of sparing the healthy tissue? That is, I would say, the more important question. And I absolutely agree. Depending on the region in the body, you can argue, I have an excellent alternative with photons available. What is really the benefit? Is it just 1% or not? And this is, for example, the approach Dutch colleagues follow. They have the so-called model-based approach. So they try to find NTCP models predicting the expected amount of toxicity, and only if they have a certain threshold, they would say, yeah, the patient is eligible for particles. When we talk about brain tumors, the proximity of critical organs at risk is so critical that, to be honest, I wouldn't see any constellation where you couldn't go for particles, for protons mainly, because you treat your tumor volume and you spare the lenses, the retina, the pituitary, the inner ear, the brainstem, you name it. So there, I wouldn't see a reason why not to treat with photons first. And for head and neck tumors, again, a teaser for tomorrow's Heidelberg approach on clinical trials. We often use a combination, a mix, because we say carbon ions and the biological advantages of light ions, heavy ions, they are only true for macroscopic tumor. So you really need to concentrate on the disease itself.
Okay,
And
so
in my opinion, there's no good rationale to perform, for example, elective. Sorry?
No, continue.
Okay, so to concentrate on the tumor, and in my opinion, there's no good rationale to perform elective node irradiation with carbon ions to the whole neck. This can be easily done with photons or with protons. So the clinical impact should always lie in the center.
Okay, thank you. And the third question is, what is the way to make constraints dose estimation for re-irradiation after 6 months?
Yeah, very, very good question, but it's not easily answered. This is exactly what causes headaches to us as well. because it is very individual situation. Depends on previously treatment, because you have also influencing cofactors like number of previous surgeries, comorbidities, concurrent chemotherapy, neurologic deficits, tumor extents. Is there still macroscopic disease? Is the tumor still, for example, causing pressure on a critical organ? For example, let's say if we have compression of the optic nerve, is the tolerance dose of a compressed optic nerve over a relevant amount of time, several months, still the same tolerance dose than a optic nerve that has never been touched before? So these are typically very individual situations, and there is no general answer to that. If there is something like a general answer, then that you can assume more recovery after a longer period. So this is at least what we do. If we have a time interval of only 6 months, we assume less recovery than if we have an interval between 1 or 2 years. And once the treatment is 5 years or more ago, then we go to even higher values of recovery, but very, very individually.
Okay, thank you, Daphne, for sharing the document. There is a hand raised. Please unmute and ask your question.
Hi, can you hear me?
Yes, very well.
I am Dominga Cataldi. I wrote the first question. So let me explain well. In page in slide 12 here, in the image at left, there are two sub-images, A and B. I would like to understand if the first image, A, represents interaction with photons, and in the second image, B, it is the interaction with the protons or not.
Yeah, this is absolutely correct. If we look at the image we just see on the screen, we have the column A of 3 representation, axial, coronar, and sagittal. And on the left, the A column is the photon plan. And on the right side, the B column is the proton boost. And this was just picked to visualize the matched pair analysis. As usually for a matched pair analysis, you not only look at the comparable amount of patients, but they should also have similar clinical factors, amongst them age, comorbidities, Karnofsky performance index, but also localization of the tumor and especially tumor volume. And this is just what this image should visualize, that we really have comparable clinical situations in the matched pair cohort.
Thank you.
There is one more question in the document. Daphne, please go ahead.
Yes, we have one last question, and the question is there any reason to split IMRT and proton boost and not treat entirely with protons?
I would say yes, but rather for non-CNS tumor. Again, the teaser for the clinical trial session tomorrow. The Heidelberg approach followed, especially in the beginning, often a combination of primary photon plan. This has historic reasons, because the resource when we started our clinical pilot project for the particle beam was even more limited. So they received a certain amount of radiation with photons, and then followed by either a carbon ion boost or proton boost. The approach has changed right now. For some entities, we still have this combination concept, especially for head and neck, adenoid cystic carcinoma, salivary gland tumors. We still follow IRMT as a primary plan, mainly for elective irradiation of the CTV, and then concentrate with a carbon ion boost to the macroscopic disease.
Okay,
Thank you. We're
very
a bit
much.
out of time, but let us take, there is a next question in the document and a raised hand, and this is where we stop the questions. So then you can continue typing in the questions in the document and we will try to answer them in written. Please, Daphne, go ahead and read the question in the document and then we will take the raised hand.
Yes. So the question is, what is the recommended dose of reirradiation with protons after first irradiation with photons?
Yeah. Whenever using protons, you can use basically the same regimens you use with photons. I just showed that quickly on one slide. We regard protons as well as low LET irradiation. Of course, we use a fixed factor still of 1.1 for the RBE and then the biological dose, but basically you use the same fractionation. So if you use reirradiation 36 gray in 12 fractions, then you can also perform mild hypofractionation with protons.
Thank you very much. So I see Fatima raised hand. Please unmute and ask your question.
So, hello everyone. I have a question. We talk in general about reirradiation of a carbon ion or a proton after photon radiotherapy. My question, is it possible to have reirradiation of carbon or proton radiotherapy after electron radiotherapy?
Basically, yes. The same rules apply. That you need to be aware of what volume was irradiated, what is the amount of dose absorbed by the surrounding organs at risk, and by your target volume. But in general, it doesn't make a difference whether it was cobalt, photon, proton, or carbon irradiation.
Okay,
Yes.
thanks.
Thank you very much for answering all the questions also. It was an interesting discussion, anticipating also the presentation on the clinical trials. I'm wondering if it is possible to design a clinical trial focusing on the spared organs and the positive aspects of saving the healthy tissues rather than comparing the effects on the tumor itself. This question comes again and again. So here we thank you very much.